So what I'll be talking in next 20 minutes, the role of surrogate azar in managing high triglyceride. I don't have any conflict of interest for this particular talk in on this platform, but because it's a product which is product related talk, so definitely um, in disclaimer I can say that it is one of the company who is making, and in India they are the one who are the manufacturer of this product. I start my talk that Asian Indian phenotype is really different. We are thin fat Indians. We have high visceral fat. We have higher insulin resistance. We have markers. We have high LDL, low HDL, and high triglyceride. And this LDL is also a small dense LDL. We have early beta cell destruction in patients of diabetes. We have early onset of diabetes, and we have higher risk of diabetes complications. So, I mean, this is a typical of Indian phenotype, what we are seeing most of our patients like this. One very interesting and very important thing, as we give all our patients high dose of statin, and there's a primary therapy, but still there is a significant residual CV risk even after giving a intensive high dose statin therapy. And this, even after giving a significant reduction in LDL, this significant residual CV risk remain a major issue for us. And even after treating all our patients with high dose statin, still there are many patients who have very high CV risk also. So is it a high triglyceride? Could it be a contributing to residual CV risk factor? So if I just present this paper, which was in 2015, which was published in American Journal of Cardiology, that fasting triglyceride predict the recurrent ischemic events in patients with acute coronary syndrome who are treated with statin. And this paper had shown that even after the patients who are treated with a high dose of statin, still there is a fasting triglyceride can predict the recurrent ischemic events. And this paper was outcome of two major study, which was one was DAL outcome study, and other was miracle trial. And that had shown that fasting triglyceride is an independent of LDL cholesterol having a risk for cardiovascular risk. So it's a fasting triglyceride which predicts here, and you can see here the patients who have higher than more than 130 to 175, they have higher CV risk in compared to the patients who have lower triglyceride also. In the other study, which was a miracle, which had also shown the same, that hazard ratio of CV events in patients according to quanta tertile, those patients who have higher than 195, they have more CV risk in compared to the patients who have less than 195. So these two data are significantly shows that strong triglyceride level with residual risk after acute coronary syndrome in patients who are receiving effective statin therapy, still they have significant risk of acute. One more article which had also shown that elevated triglyceride level is independently associated with increased all-cause mortality in patients with established coronary heart disease. So I mean, it is independent of all other things. A high triglyceride level is responsible for with established cardiovascular disease increasing the all-cause mortality. And this hazard ratio, if you just see, higher the triglyceride level with more than 200, you can see more than 150 significant increase in the risk of mortality. A 22-year mortality risk for patients with severe hypertriglyceridemia was increased by 8% when compared with patients with no low normal triglycerides. I mean, there's a direct association, and this 2 years, which was published in 2016. There's one more paper which was a strong heart study where more than participants who are free of cardiovascular disease at baseline on a community-based prospective cohort of American Indians were studied. The fasting triglyceride was categorized into normal and high triglyceride, and fasting HDL were also categorized in normal or with low HDL. And results you can see in patients with diabetes and without diabetes. And you can see the patients with a higher triglyceride with a low HDL, whether with you consider in the diabetic patients or a non-diabetic patient, the risk of mortality patients who are having high TZ with low HDL. The ischemic stroke as well as coronary artery disease both were high in the patients who are having high TZ and low HDL. So is it the high triglyceride which is to be treated or not? question. Let's say $1 million question, because all these are data show that high triglyceride is more for the coronary. It whether we are going to have less or less coronary artery disease, that's a question, and that's whether this to be treated or not. The question is such type of question because field study and accord study had not shown any benefit even after treatment level. But what was the mean baseline triglyceride? Now, this is very important for all physicians friends to understand that field trial and accord trial, the mean triglyceride was 155, and in accord it was 162 only. So by treating almost like a normal baseline TZ, how you can expect a CV benefits. Now let me come to the meta subgroup of the patients in the accord and field, and also some other 5 other landmark study where we could have the patients of more than 4,726 patients, and you can see with the patients who have high triglyceride baseline value more than 204, you can see there is a significant difference by treating them as far as their coronary artery disease risk is concerned, and this paper was published in New in 2010. So there is a definite benefit of treating triglyceride level. Also, there is a 35% relative risk reduction with TG lowering therapy by whatever the way you have treated them in patients with a baseline triglyceride value of 204 with a HDL of less than 35 or less than 34 milligram per deciliter. So this is very important, a paper which was published 5 landmark study. They combined with a patient group of more than 4,700. The CV risk reduction was one in more patients with a reduced IT trial with a hypertriglyceridemia, but they had used icosapent ethyl, and this is a multicentric trial where more than 8,000 patients were taken. The baseline triglyceride here again was the 216, and in this reduced IT trial you can see a significant risk reduction by 25% risk reduction of CV events. This is the paper in reduced IT, and they had shown those patients with a baseline triglyceride level. There was a risk reduction of cardiovascular risk reduction by treating these patients with icosapent ethyl. The role of saroglitazar, let me talk about the particular drug, because this we had talked about the high triglyceride, whether by treating high triglyceride by whatever way, will it have a benefit or not. Now let me come with the saroglitazar, which had with 13 years of research. If you just see the identification of a chemical compound which was done in 2001 by Jaidas Kedila, and it was launched in 2013, and now we are sitting in a almost 6 to 7 years of post-marketing exposure of this molecule from concept to clinic. Saroglitazar mechanism of action is very clear. It is with alpha action, it reduces triglyceride and reduces non-HDL, but with the gamma action it improves the insulin sensitivity also. So the primarily with improving insulin sensitivity and primarily alpha effect, which improves the lipid profile, primarily triglyceride level, and this is a unique mode. It's a dual mode of action with PPR agonist alpha and gamma, where it improves not only the insulin sensitivity but decreases the triglyceride level also. Previously there was also glitazars, but primarily they were on gamma, while this is primarily a predominantly on alpha, and that is one of the reasons that it is more potent with fenofibrate, and other side it is also more potent with the glitazone also. So lipaglyn comes somewhere here, the saroglitazar comes somewhere here. I don't know how many of you know about the Gujarati language. Saro mean good, so saro mean good, and that's the reason the name of this glitazar is been made as a saroglitazar. Saro mean a good glitazar by Gujarat, and that's the reason in Gujarati language it is known as saroglitazar, saro, and that's how the name of this molecule had come, a saroglitazar, because before that all glitazar which were there, they were not saro, they were not good, and they were having a lot of side effects also. So the primarily the saroglitazar is not only increases the insulin sensitivity. This is one of the paper which had shown hyperinsulinemic euglycemic lab study where it had shown it improves the glucose level also decreases glucose level and improves the insulin sensitivity. The safety is well established with the PRAISE 5 and PRAISE 6 studies, where it has shown that it is very, very safe and well tolerated, no increase in the weight gain. Also, years post-marketing had shown that it is no adverse event or serious adverse event has been reported. Even now we have more than 65 6.5 lakhs 65,000 consultant had used it, and more than 1 million patients of diabetic dyslipidemia were treated by the saroglitazar in India, with more than 55 publications in post marketing in last 6 to 7 years. If you see the efficacy by TG lowering 46%, non-HDL lowering by 32%, FOB reduction by 32%, HbA1c reduction by 0.3. But the latest data which I am going to show, that it has reduced almost more than 0.5, and that's the reason now that recently it has been approved as an anti-diabetic medication also in India. And when it was compared in this particular study, which was published in 2014, where it had shown HbA1c reduction of 0.3 when it was compared with the pioglitazar arm, there was no increase in weight, only 0.1 while 1.6 kg in a pio arm. So in a randomized controlled trial, it had shown a significant TG lowering benefit as well as some HbA1c reduction also, and there was no increase in body weight too. This is the paper which is very recently published in Diabetes and Obesity International Journal, where 158 patients with diabetic dyslipidemia, and they were followed up for more than 1 year. This is an observational study to see the metabolic parameters of Indian patients with diabetic dyslipidemia. Completely, this was a 158 patients who were followed up, and you can see not only the HbA1c reduction. This is the 7.25, the baseline from 7.9. You can see here 0.65. The cholesterol level from 181 to 148. HDL, there is a 38 point, is almost no difference. But triglyceride here you can see from 319 to 174, very, very significant difference. So some difference in HbA1c points, triglyceride significant difference, very, very HDL same, no difference. Much of the difference was with LDL, but non-HDL is also significantly reduced in the patients who were on this triglyceride lowering agent saroglitazar. And this paper was in 2018 with 158 patients for a 58 weeks follow-up. This safety parameter, if you see, the SGPT, SGOT, and creatinine, they are completely safe at the follow-up, and in baseline there was no, rather there was an improvement in SGPT and SGOT, like we were expecting, as it is an insulin sensitizer, and no difference as far as renal dysfunction was concerned. The other paper, which was published in JAPI, the study of saroglitazar in treatment of pre-diabetes with dyslipidemia. Here dyslipidemia is, these are the patients with higher triglyceride with low HDL. The 40 patients, again in 2018, these 40 patients were having pre-diabetes with dyslipidemia, and these subjects were ongoing medicines. The saroglitazar once was administered for these patients for 24 weeks, and the primary outcome was to see the triglyceride, but the secondary outcomes were other lipid parameter and HbA1c after 24 weeks. So this trial they had named as treatment of pre-diabetes and dyslipidemia. So in dyslipidemia and pre-diabetes, what was the role? And here you can see the patients, this was the baseline. Total cholesterol was very, very high, but still it is decreased. The triglyceride significantly decreased from 348 to 216. LDL cholesterol also decreased. HDL, there is a minor, some improvement. HDL significantly decreased, and even HbA1c, which was in a pre-diabetes value, had gone to non-diabetic, which is 0.7. So I mean, this is the drug which had been used in pre-diabetic patients also with a high triglyceride level, and you can see here with the 24 weeks, the HDL, I mean improvement in HDL, decrease in triglyceride significantly, decrease in non-HDL triglyceride, and HbA1c reduction by 0.7. The high triglyceride level increases small density LDL fraction, which are then large beyond LDL. So this is also why we should treat high triglyceride, because high triglyceride itself is a risk factor, both because it increased the small dense LDL fraction. So by treating the high triglyceride level, you are improving the LDL cholesterol value. One more trial which has shown the prospective multicentric study to evaluate the effects of saroglitazar cholesterol along with small dense LDL particles, and this was done by Upendra Kaul, which was published in American Diabetic Association in 2018. The results you can see here again. The patients were LDL cholesterol, they had primarily targeted LDL cholesterol. This is the from 90 to 82. The small dense LDL cholesterol they had done with 31 to 26. So this is the only one study which has talked about the small dense LDL cholesterol and which had shown there is a significant improvement in small LDL cholesterol also. There is a one more with the HbA1c reduction was also there from 7.98 to 6.95, which is significant difference. The 351 to 247 also. The effect of dual PPR gamma alpha agonist on insulin sensitivity in patients with type 2 diabetes who have hypertriglyceridemia, a randomized double-blind placebo-controlled trial, again from India, which was published. And that had this trial was a single-center trial, double-blind trial. Now type 2 diabetic patients with HbA1c of 7 to 9. These were completely treatment naive. Only 30 patients when the triglyceride value were more than 150. Subjects were randomized to receive either saroglitazar or placebo in 1:1 distribution for 4 months. The patients with the study duration. And here you can see the fasting plasma glucose. These were the 4 months. It is decreased from 141 to 100. From the saroglitazar arm, it was from 154 to 115. If you see the HbA1c, it has also reduced because of lifestyle modification, 7.7 to 7.2. Here the baseline was 8. With the base now it had come to 6.7. Insulin sensitivity. At baseline 2.3, 2.9. At 4 months, 3 and 6. It is increased by almost 2.5 times. The HOMA IR. The baseline here you can see the at 4 months it is significant. Resistance is decreased. HOMA beta also had the significant improvement in HOMA beta cell function in the patients who were treatment naive and they were started with saroglitazar. So you can see a significant difference in that. In this particular trial, the placebo arm and triglyceride arm, the patients who were on the triglyceride arm was the 325 and they decreased to the triglyceride level of 209. So in conclusion of this particular trial, the saroglitazar effectively reduces high TZ, improves along with beta cell function by reduction of glucolipotoxicity and possibly direct PPR gamma agonism in patients with type 2 diabetes with high triglyceride level. One more recent publication which done in American Association for the Study of Liver Disease, because saroglitazar they are equally promoting in the patient with NAFLD or NASH also, and this paper had shown the two-phase study which was done in NAFLD, particularly in US, which was published here in a where 106 adult patients with NAFLD and NASH. They were used with a patient with SGPT of more than 150, with higher BMI of more than 25. These patients were put either on 1, 2, and 4 milligram in 23 centers in US. Primary efficacy endpoint was in SGPT level from baseline. Key secondary efficacy points were proportion of the patients with more than 50% reduction in SGPT level and change in liver fat content also. And you can see here the significant difference in primary efficacy. The SGPT, which was from 44.39, this is the percentage change. You can see with the placebo, there was no percentage change, but this was the percentage change even with 1, 2, and 4 milligram. And if you see all the secondary absolute endpoints, the absolute change in liver fat content, the percentage of reduction in liver fat content by more than 10%, more than 30%, and percentage change in the weight, they all were significantly decreased in the patients who are 2 and 1 in placebo. And reduction in other parameters like in HOMA IR was decreased from 5.1 to mean triglyceride from 70.3 millimole to 3.4, total cholesterol from 24.2 millimole to 4.4, mean fat content from 4.2 to 1.3. So in it has significantly improvement in hepatic steatosis, insulin resistance, and dyslipidemia. So this new dual peroxisome proliferator activity is saroglitazar in diabetic dyslipidemia as well as in NAFLD. It had shown a real great evidence, and which was one again published in 2019 by Upendra Kaul and by Dr. Devan Parmar, who is a scientist from Zydus. They had published this paper which had shown how mean change in the baseline in triglyceride level, and they had shown from 517 to 196 in their patient population across all selected study, and there was a consistent mean reduction in triglyceride value. So how they are differ? I mean, we were using fenofibrate since years, and for the triglyceride reduction, whether we should change to the saroglitazar, one of the biggest reason why we should use it because of fenofibrate side effects, and that I'm sure all of you will agree, from myopathy to rhabdomyolysis to the renal dysfunction to the hypothyroidism. Everybody will you agree, while the saroglitazar in all trials, in all post-marketing data also, it had not shown any side effects. I mean, significant adverse reaction. Liver function, again, they rather increase, and because it is an insulin sensitizer in a diabetic patient in the higher triglyceride level, they have simultaneously NAFLD and NASH also. So rather it improves, it helps both the place. One side, it improves the insulin sensitivity, decreases triglyceride, decrease HbA1c, and decrease the liver enzyme also. Overall in metabolic syndrome, it helps also. In renal function, it reversible increases the serum creatine level. Saroglitazar does not have any effect as far as creatine value is concerned. The root, again, you can't give fenofibrate in the patient who has renal dysfunction, while saroglitazar can be given in the patient safely in patients with renal dysfunction. So now there is still global multiple clinical trials are going on from all over the world, and there are multiple clinical trials had happened in this. One of the clinical trial phase 3, which is going on in Europe for an HIV lipodystrophy also in some of the patients, and dyslipidemic trial all over the world, even with the NASH and NAFLD also they are doing the trial all over the world. There are multiple clinical trials which are going on, and it will be one of the first Indian molecule with the origin from the phase 1, which is started from probably gate. And we already have evidence against NAFLD, NASH, diabetes, as well as for, and it will become a drug of choice for treating triglyceride level or in the patient with NASH or NAFLD at all over the world. So the journey so far, it is a dual PPR action, predominantly PPR alpha, preclinical carcinogenic potential. 2-phase study had shown randomized control trial safe and effective. Saroglitazar completed its clinical journey of more than 6 years. It is safe and well tolerated, not associated with weight gain or edema. Significant improvement in triglyceride or not, and there is an additional benefit of insulin sensitivity and improving the glycemic parameter. As we know that raised triglyceride is an inherent part of diabetic dyslipidemia, and it considered to be an independent risk factor for CVD. And this is very important, I must tell in my conclusion slide. The current international guideline recommend the treatment of more than 200, which is not controlled by intensive statin therapy. The use of dual PPR alpha and gamma agonist saroglitazar 8 weeks was associated with significant improvement in both glycemic and lipid parameters among Indian patients with diabetic dyslipidemia. And as it is very well tolerated, there is no serious adverse events which was found with saroglitazar. So it is one of the safest molecules with high triglyceride level. With this, I thank you. Thanks everyone. And